Welcome to the Department of Medicine Grand Rounds here for October 7th, 2022. My name's Sterling Johnson, and I'm faculty in the Division of Geriatrics here in the Department of Medicine. And it's my pleasure to introduce our speaker today, Dr. Carey Gleason. And I'm presenting on behalf of Dr. Asana, who's the chief of the Division of Geriatrics, and also, of course, our department chair, Dr. Lynn Schnapp. So our speaker today, Dr. Carey Gleason, has been in our department for quite a while. She's well known to us. She's a clinical neuropsychologist and has a thriving, internationally prominent research program that we're going to get to hear about today. Dr. Gleason's lab strives to improve diagnosis and treatment of Alzheimer's disease and dementia for individuals, for all individuals, including women, African Americans, Native Americans, and other groups that are traditionally underrepresented in research. Her lab is founded on the premise that diversity makes for better research and that discovery should benefit all groups. She's a researcher and a clinician interested in improving timely identification of Alzheimer's disease and related disorders and intervening in a way that improves quality of life. Ultimately, she seeks to identify targets to modify risk for Alzheimer's disease in African Americans and Native Americans, groups that are traditionally underrepresented in research. She serves as the leader of the Inclusion of Underrepresented Groups core in our Alzheimer's Research Center here at the UW. And she's principal investigator or co-investigator on numerous NIH-funded research projects examining modifiable risk factors, including cardiovascular disease, emotional health, and social context. We're excited for Dr. Gleason's presentation today, and please join me in welcoming her to the podium.
Thanks, Sterling. I appreciate the kind introduction. So it's nice to be here in person. Thanks for coming out today. I appreciate that. I've been doing a lot of these talks to a computer screen, so it's really nice to change it up and get back to the way things used to be. So these are disclosures related to CME. I'm sure you've all read that quickly. So I'll be talking today about conducting inclusive research and sort of the why, the how, and hopefully some principles that we can begin to think differently about the work we're doing. So first I want to thank co-authors. These are my science collaborators. You'll see that there's lots of different people on this slide because this work is so multidisciplinary and it takes a lot of partnerships. And things including partnerships for things like data sovereignty work and the funders, the community advisory boards, and also very central to this, of course, our participants in Oneida, in Milwaukee, and Madison. So things I want to talk about today, I'd like to first, the why. Why would we be focused on addressing racial disparities in Alzheimer's disease? What are the data behind that? And then to begin to think about how we address these disparities in a way that involves inclusive research as a means to address that. And then finally, what we're doing with African American communities here in Wisconsin. And I'll present some of the science that we've been able to accomplish because of these inclusive research practices. And then what we're doing in Indian country as well. And then finally, if you can indulge me for a few minutes on the soapbox, I'll wrap things up with some concluding remarks. You'll see abbreviations as we go forward. Alzheimer's disease abbreviated as AD and ADRD, Alzheimer's disease and related dementia. So bear with me if I lapse into my alphabet soup here. But I want to first just orient us and to maybe ground us in this discussion. This is one of my favorite writers, Toni Morrison. And she is describing how she conducted her art in a way that led to a shift in perspective. And I chose this quote because I feel like all of us here in the room and on the call can begin to think about how we see our world and what the borders are. And if we can expand our viewpoints by doing what Toni Morrison did. She stood at the border. She stood at the edge and claimed it as central. I claimed it as central and let the rest of the world move over to where I was. So this is a little preview. I'll come back to this quote as we begin to think about shifting our worldviews in a way that we expand how we think about the work we're doing in inclusion in research. So now shifting to the topic of racial disparities in Alzheimer's disease and related dementias. This might not be a surprise to people here in the room, but perhaps it will be. Before I do that, though, I just want to make a comment about what I mean by race. Race is, this is a strong belief of mine that race is a social construct. It is a marker occasionally for some biological factors, but in large part, it's a marker for how the world treats us, how we experience the world in our culture. So, how do we decide what race is? Oftentimes, people's experience is based on what we look like. So race is imposed on people in the sense that, so I'll use the term racialized, meaning that people look at you, decide what race you are, and treat you in a certain way. And that, in large part, is what frames much of the health disparities conversation. So you'll hear me use terms like racialized or minoritized. And again, the function of that is to recognize the source of those characterizations. Race can also be a source of great resilience. Tapping into a person's context and their identity. So it can be a mixed bag, but my colleague Molly Carnes has talked about oftentimes what race can tap into are stereotypes. And it's sort of a lazy cognitive approach to see race and then think stereotype. It's unfortunately a habit that most of us have, but this is something that race is a marker for. So just to explain what I mean by race. So first, let's just talk about incidence of dementia. So the likelihood of developing dementia in these different age brackets. And this is data from Mejita in 2016, where she looked at the Kaiser Permanente data sets and individuals self-identifying their racial identity. So you'll see in almost every single one of these age brackets, the blue bar and the light blue bar and the green bar are African Americans and American Indians. And as my friends in Indian country or in the African American community talk about, they're always #1 on the list. So it's an old story for them in terms of their understanding of things like risk for disease. The same holds true though for dementia incidence for both groups. Same thing true for mild cognitive impairment, considered to be to precede Alzheimer's disease. So this is looking at more recent data from Rajan. And the estimate is that African Americans have 1.5 to 1.8 times higher risk or prevalence, excuse me, of Alzheimer's disease and related dementias. So what is going on? What's the story behind that? There was a really nice paper this year that came out that looked at risk factors for dementia. So there's a school of thought, basically there's a sort of set stream of factors that influence whether or not a person gets dementia. And then there's also a group of modifiable risk factors, a separate stream that follows parallel to your biological risk factors. So if we look at those modifiable risk factors in almost every category, things like hearing loss, smoking, diabetes, depression, midlife hypertension, education, physical activity, and obesity, if we combine those, so if you look to the left of your screen, the combined columns, those groups who have the most, the highest combined risk of these modifiable risk factors are Black and Indigenous populations. So the American Indian group here is in sort of a salmon color, and Black or African American is in a light tan group here. You'll notice Hispanic population, of course, an ethnic group is not too far behind. But look at this, the white population is emerging as having higher attributable risks as well. Things like obesity, physical activity, all of these things, unfortunately, are growing in the white population as well. And I would posit that this is largely related to economic status and to access to things. So it's most likely a rural population, white population, that's being affected in this way. So what do we know about Alzheimer's disease specifically for American Indians? Very little. But what is out there points towards, of course, a higher risk. I just showed you data on prevalence, incidence, and attributable risk due to risk factors. The Alzheimer's Association did a special report in 2021, and their estimate is that 1 in 3 American Indian elders will develop dementia. So about a third, which is, it's not going to be a small number. And hot off the presses, one of a junior faculty working with me looked at the healthcare utilization costs for American Indians in Wisconsin, and basically found that once a person is diagnosed with dementia, the healthcare costs double for American Indians. I suspect that is higher than the white population, in large part because there are differences in access and a timing of diagnosis. So this is not going to be something that we can ignore as a society in terms of the societal costs. So moving next to how do we begin to approach this question? And this is my humble opinion. I think we do this by like we do with science, correct? Science can solve so many things, but science has to be done in a way that is inclusive if we really want to address the health disparities. So let's take stock. Most of you have heard that the field of Alzheimer's disease treatment is moving towards disease modifying approaches. In the past, we've relied on treating the symptoms. So this is a really exciting time in the field, that we are, for the first time, finding a foothold in those drugs that can modify the actual disease course. So I'll talk a bit more about what's happening in those early or preclinical stages of the disease. But you might have heard the news. This was pretty exciting within the Alzheimer's disease world in terms of the controversies. About 1.5 years ago, the FDA approved, against the recommendation of their advisory council, they approved the drug Educanumab. And they approved the drug in large part because there was a subtle signal. The advisory committee did not agree that that subtle signal warranted approval. It kept the field alive though. And now we have a new finding emerged just this last month about lecanemab, another drug that does seem to actually meet clinical endpoints. I tell you this backstory because one of the other controversies that arose out of this original aducanumab approval was the population on which that was included in the studies supporting that application for approval to the FDA. They had 2 studies that supported the application for approval with a total of over 3,000 individuals enrolled. And it was hard to find these data. A colleague of mine had to actually go in and dig to find these specific data on race and ethnicity. And she reported this finding later on in 2021. What does the aducanumab approval reveal about Alzheimer's disease research? Maybe Alzheimer's disease research is not alone in this field. Those of you who work in other areas might be asking yourself the same question about how you're doing in terms of inclusion. So in this, of those over 3,000 individuals who were included in that study, 99 identified as Hispanic, 19 as Black. There was 1 person who self-identified as American Indian, and 1 person as Native Hawaiian or Pacific Islander. I bring this information to the Black Leaders for Brain Health or to my Oneida cab, and the first questions they ask me is, well, is it going to work with me and my family? A huge blow to the level of trust that communities have in these data if we can't even stand up and say that, yes, we know that this works because you have been included. So we have a ways to go. Fortunately, the Educanumab data, it looks like they did a much better job of inclusion. They report somewhere between 20 and 25% of that data set included individuals who identified from an underrepresented or racialized group. We don't have the more precise data as of yet, but we'll see. So what's happening? Why are we not including people? And oftentimes I'll bring this conversation to my colleagues and we know that communities of color don't trust research. And for good reason, I'll put it out there. Most people have heard of the Tuskegee syphilis study. For those of you who have not, I encourage you to look into this and read about it. But I would say that probably most people in this room or most people on the call have heard about it. The study was intended to understand the natural course of syphilis. Over the course of the study, as they were enrolling primarily Black men in the South, who what they were told about what they were enrolling in was minimal, that they were a study of bad blood. As the natural course of the illness, a treatment came out. The investigators decided not to tell those men who had syphilis that there was a treatment, that they had a disease that now had a treatment. And it caused great harm to people. And that's not the goal of research. The study valued the scientific aims over the humanity. Major problem in the ripple effect and the long-term effect of that study and what it has meant to the Black community is longstanding. I also get this comment, well, that was in the past. When can we move forward? Unfortunately, there are more recent examples, and people in the community know about this. So tell me if this sounds familiar. Johns Hopkins did a study where they were looking at lead abatement practices. So they went in and they knew that there was lead in these homes where families were living. And this was in the poor neighborhoods of Baltimore. So they didn't necessarily target Black families, but there was an overrepresentation of Black families in this study. And they did not reveal to those families if there was lead in the home, because they were studying the practices of lead abatement. Again, we valued, in those cases, science over the humanity. So there was a lawsuit, of course. And again, families know about this. The Havasupai tribe in Arizona formed a relationship with a researcher who was studying diabetes in the Havasupai and the genetics of it. Very important question. The Havasupai were like, yes, we need to know what's making us sick. So they signed up for the study. The genetic data were banked and then unfortunately used for other purposes. This happens all the time in research, right? So here's where the Havasupai came back and said, your research now is affecting things about our story. So the data were used to study things like schizophrenia and migratory patterns. Came to light because a graduate student was doing a presentation on the migratory patterns. A Havasupai faculty member was in the room and said, you're challenging our origin stories. We're from the Grand Canyon, and you are saying that we actually migrated over the Bering Peninsula. So all of these factors just led to this continued mistrust. Samples actually were returned to the Havasupai at some point, but not after a very contentious lawsuit and a battle that has actually had a chilling effect across Indian country in research. So, and you might say, well, again, that trust is a major factor, and that this is going to lead to always an underrepresentation in research. But guess what? We can enroll, we do manage to study Black people when we don't have to get consent. So this is data. This is just a flip side of this. It's just an unfortunate story too. If we don't have to get consent, in this case, African Americans were disproportionately enrolled in studies that don't require informed consent. I ask you to think about this now as you look at data sets. How involved were the constituency in terms of these data? Ask these questions about who's interpreting the data. Is anybody on the team? Do they look like the people that they're studying? Because there's a possibility that we bring our lens and our interpretation to these data for people who never signed up for the study, and we make interpretations. So the story has emerged. So of course there's mistrust. We acknowledge that. And for the most part, my colleagues never argue with this and saying, yes, there's mistrust and there's limited access. But here's where the flip comes. I want us to move from that center to the border at this point and to begin to think differently about this. Recognize we have a culture in our research. And every time you're doing research with a community who is underrepresented in research, we are managing to negotiate an intercultural exchange. And when you are doing that, you acknowledge your own culture in a way that you can begin to question some of the things that we bring to this intercultural exchange. This is a model that many, many people are using. I'm not the only one using this. I want to really give credit to those who are doing this great work. My colleagues here in Wisconsin with Gina Green Harris and Andrea Gilmore-Bukowski, my colleagues in Chicago. It's just, this is a model that's been done many, many times. An emerging area of the field is the science of recruitment work. So I'll tell you a bit more about that later. So the model that we're using here in our inclusion of underrepresented groups core is we go to communities. First of all, it's ideal if you're asked. How many in the room have ever been asked to make a presentation with a group that maybe historically has mistrust? Is anybody? Okay, well, it happened with us. And we were so fortunate. It started with a conversation at a recruitment table. A group of elders from Oneida walked up to our table and said, hey, where's the data on Indians and Alzheimer's disease? And we kind of shrugged our shoulders and said, we don't know. And they said, based on their own experience with Alzheimer's disease, they wanted to know more. They said, will you come up to Oneida and give us an education talk? So we did. And that started the ball rolling in terms of the ongoing conversation and relationship. Our Black Leaders for Brain Health, before they were the Black Leaders for Brain Health, they were community members who were asking questions, saying, I want to be involved in the science. Give us the education so that we can actually ask and frame out some of the scientific questions. You'll find this when you go into a community. If you're studying diabetes or heart disease or cancer, you'll go into that community and you'll hear the stories. Those people are saying, I've been personally touched by this illness. I guarantee it, because the prevalence, the rates are higher. And then they come back to you and say, I want to advocate for this. So there naturally, these advocates emerge organically. And here's what you can do. Put them on the payroll. Hire them to be your liaison. And then what happens as the programming grows, there's a natural organic reciprocity that happens as the relationship emerge. So here's, I'm gonna go back to that recentering. A dear, dear friend of mine and colleague, he and I have had many conversations about the culture of research. I encourage you to check out his paper here, the title of which is Personal Experiences with Tribal IRBs, the Hidden Hegemony of Researchers. And I always go back to him and say, it's not so hidden, Neil. The hegemony, that feeling that we are this is the way to do it. This is the best way to do it. Why would we do it any other way? Let's begin to think about this differently if we can. And start to redefine recruitment. It's not recruitment, it is engagement. It's a relationship. And successful recruitment, it starts, begins, and ends with that engagement in that relationship. So a colleague of mine or a friend of mine in Oneida, talks about, we're Indian. We've been studied right, left, and center by everybody. They come and take our nail clippings and our hair and in those cases, it's about people coming in and studying a convenient sample and studying them for the goal of science, as opposed to the goal of giving back to the community and helping. So I'm sure the Black communities I work with can describe the same thing. It was a convenient sample where you didn't have to do a whole lot of legwork to get people to participate. Then, therefore, the Tuskegee study of neurosyphilis. So if first step, we acknowledge that we have a culture and that we have values and we have a viewpoint that this is the best way to do it. And then we begin to think about that intercultural exchange. So let's talk about what we can do. If we are able to sort of bridge those worlds and set aside our own bias in terms of like the best way to do things, what can we accomplish? So I'm going to tell you about some data that we have from the AA-FAME study. The AA-FAME, African Americans Fighting Alzheimer's Disease in Midlife. Midlife is a really important time period for Alzheimer's disease. This is one of the only cohorts that I know of that has a large cohort of African Americans specifically focused in that cognitively healthy phase of midlife before symptoms. And the model of AA-FAME is to first build that infrastructure. So a lot of you probably are thinking, well, how can she afford to do all of this outreach and engagement? You bake it into your research project. So heavily invest in that research, in that engagement. I am so fortunate to have here the colleagues that allow me to then leverage that connection with existing infrastructure. So the WRAP, the Wisconsin Registry for Alzheimer's Prevention, and the Alzheimer's Disease Research Center's clinical core have the infrastructure for longitudinal observational studies where you can, and the visits are intense. So we're asking for a heavy lift for our participants, 5-hour visits, lumbar puncture, PET imaging, coming back every year. So these are big lifts. I'm fortunate to have colleagues who are saying, yes, we can leverage those resources. You do the recruitment, we'll recruit into these existing cohorts. And very importantly, this is another key, there's not a competition. People are not viewed as commodities. They're enrolled in these studies. The data that's generated then can benefit multiple scientists. My goal with the AA-FAME R01 is to make sure that we are using those data that are collected to answer questions that are specifically relevant for African Americans and will advance the health of African Americans. So the AA-FAME, we just went in for renewal in March, happy to say. This is data as of September. We've now had we've had baseline assessments from 424 participants. And most people say, oh, it's probably all Milwaukee, right? More than half have come from right here in Madison. So very important partnerships with Milwaukee and Madison, but my friends, my Black friends in Madison say, there are Black people in Madison. Please don't ignore us, we're not invisible. And it's a very active partnership with the Black community here. And much so dependent on that relationship and that engagement. A number of data have been collected. We're just beginning to really ramp up collection of the PET neuroimaging for amyloid and tau, 2 proteins very important for Alzheimer's disease detection, as well as CSF collection. Really excited though about these new emerging biomarkers that are easy and accessible, including plasma A-beta markers. So I want to just depart and talk about Alzheimer's disease in general now. We know that you don't wake up with Alzheimer's disease. There's a long period of disease proteins building up in the brain. The current estimates are that this preclinical phase, this green portion on the left-hand side of the screen, lasts anywhere from 20 to 15 years. There I go back to that statement of midlife. So if average age of onset of Alzheimer's disease is in your 70s, when do you need to start looking at preclinical symptoms? How about in your 50s? So a major focus is to really look at those, and also a key point for prevention too. So if remember back to that list of attributable risk, midlife obesity was a risk factor. So let's look at what's happening during that preclinical phase. There are subtle cognitive symptoms. Oftentimes the family picks up on it. There's just something not quite right there. But there's also something going on in the brain. Here we talk about the amyloid deposition. So I'm going to focus on that in this next slide, but there's more. Tau is active, and there are other proteins that are being altered, deposited, or abnormal in this long preclinical phase. But amyloid, the current thinking is that amyloid is the starting point. So how do you measure amyloid? At this point, it's still really a PET scan or a lumbar puncture. As I mentioned, though, these emerging plasma biomarkers are really exciting. They're on the forefront of this work. Where do you get these done? Where do you get LP done? Where do you get a PET scan done? Exactly. Thank you. At the hospital, you have to come here. So how's that going to work for people living in northern Wisconsin on a reservation? How's it going to work for people who don't trust the hospital? Okay, so another area that we could look at. So these are all coming from, Black Leaders for Brain Health asked me one time saying, you know, you have to do all of these procedures. I have to be exposed to radiation, or I have to have a lumbar puncture. By the way, LP was a major procedure done in the Tuskegee study. So it's not looked on favorably for the most part. So why can't you guys do a better job of finding things that are more accessible? So when I originally wrote the first funding grant for AA FAME, I included a cognitive marker. Can we do better? Can we look at something that's going to give us a signal without having to come to the hospital? So a little bit of background, bear with me. This is a bit of a wonky nerd portion of the conversation, but I'm a neuropsychologist. So I was seeing in clinic that people would show symptoms or subtle signs of cognitive impairment with these peaks and valleys in their performance. So anyone who's worked in a memory clinic has seen this. They bottom out on one test, and they're still strong in other tests because the disease does not globally affect all cognitive domains at once. So the graph on the left-hand side of the slide shows that middle dotted line is what you would see in those early stages of cognitive impairment. You'd see well-preserved abilities in some categories, but they really, for the large part, bottoming out on memory performance. What if we can use some tools to detect that subtle difference? And one of the ones that's been published, we looked at this in data sets, intra-individual cognitive variability. So if I gave you a battery of tests, what's your variability across those different tests? We looked at this in predominantly white samples and found that it performed really well in predicting incident dementia. In fact, it performed as well as our plasma or as our CSF biomarkers. And guess what? It's a one-time test. It performed as well as MRI, where we looked at hippocampal volume over time. So a loss of volume is very predictive. So if your hippocampi are shrinking, it predicts whether or not you're going to get dementia. The cognitive variability also picked up, and again, a one-time. So there was promise there. My colleague Rebecca Kosick has looked at this in the RAP study as well, and also found that using the variability index, she was able to predict 7 years in advance of symptoms whether or not a person was going to develop symptoms. So hold some promise. So we also looked at plasma biomarkers, again, moving out of the university. So plasma biomarkers, what happens with amyloid, as I mentioned, that's one of the first things that we're looking for. As amyloid gets deposited in the brain, the levels in our fluids are dropping. So individuals who are positive in terms of their biomarker status have lower levels of A beta in their plasma, also in their CSF, by the way. Shows up in PET scanning as higher levels of deposition. So this protein, as it gets aggregated and clumps and forms these plaques, you'll see levels drop. So these are data that we use to support our application for funding, and we have a manuscript in submission right now, looking at those two biomarkers that get us out of the hospital. Intra-individual cognitive variability and plasma measures of A beta 42 over 40. Here's the take-home message. I'll show you the data in a second, but here's the message. There's promise there. The sample size was on the small side, only 200 and some. This is small compared to the white samples that are out there. But the data provided some initial support for the use of plasma A beta 42 over 40. Variability did not predict as strongly as the plasma did. However, our models were improved when we included cognitive information. So it probably means that cognitive data is adding some additional, accounting for some additional variance that's important to look at as a person is in that, especially in that healthy state of cognitive status. So here's the data to support that. We had plasma from 257 individuals who had plasma and longitudinal cognitive data. We were able to, these are young people, the average age was 62. And they were predominantly cognitively healthy. This is where I feel some excitement about. These are cognitively healthy people whose plasma levels were measured, and it still seems to predict that longitudinal cognitive performance. So there's hope there. I'm excited about these data. We'll see if they hold up. So these are the baseline comparisons. So just looking at both that variability measure as well as the plasma measurements, what we found is that there was a stepped relationship with variability. So variability did go up. And again, these are prominently cognitively healthy individuals. If we looked at, they're separating already though. If you have mild cognitive impairment or dementia, your variability is higher than those individuals who are cognitively healthy. There's a huge range there though. And then if we look at the plasma levels, we did not see the separation there. So if you just look across the board at plasma, it could again be that we've got predominantly cognitively healthy individuals, but at least at this first look at things, we didn't see the separation at baseline. However, when we look at things over time, so I apologize for how busy this slide is, I'm going to walk you through it. The top two rows for both the blue and the peach tables here tell us about what it looks like predicting longitudinal cognitive performance if you have just IICV or if you have just the plasma biomarker A beta 42 over 40. And you can see just there's a few trends here and there, but it's not real strong data. The only thing that's showing up is that plasma does predict TRAILS B performance, which is a test of executive function. We then add in the counter biomarker. So in this case, the bottom two rows on the left-hand side, IACV, if you add in plasma, you don't see much of a change in the model, and you don't see much benefit there. On the other side, though, this is where I want to pull on this thread in the next round of funding. That if we look at plasma and how it associates with longitudinal age and cognition, there's predictions. There's a hint there, and then if you add in IACV as a main effect, you do see some improvement in terms of its predictive ability. So again, something to pull on, a thread to pull on. Very preliminary data at this point, though. This is what it looks like. It's in the predicted and expected range. So TRAILS A is a simple test where I asked you to connect a series of numbers, just a speeded visual processing. TRAILS B, I add in an extra cognitive demand, ask you to connect numbers and letters in order. If you are slower, you're performing more poorly. And if it happens to be that your A beta 42 over 40 is in that bottom 10th percentile of the distribution, you are actually getting slower more quickly than those individuals in the middle ranges or in the top ranges of that A beta distribution. So in a predicted range. So if your A beta 42 over 40 plasma level is low, the prediction would be that you will be declining on these executive function tasks over time. And we see the same relationship, but in the other direction with memory, again, expected. If you are asked to remember a list of words, the more you remember, the better. So in this case, if your score is dropping, you're performing more poorly. And we see again that those individuals with the lowest level of A beta 42 over 40, those toxic ranges, we see a greater decline in memory performance. So I go back to that take-home message. Hopefully you'll agree that there's some promise there, very preliminary. And again, this is a thread that I hope to pull on in the next round of funding for the AA FAME study. We are continuing to enroll. I have another thread to pull on here. These are my colleagues, Rebecca Kosick and Toby Bethauser, who are doing some really exciting work, modeling PET imaging data, looking for the relationship of neuroimaging over time. And what they're finding is this emerging model that suggests that it's not so much the relationship of the overall level of A beta that is important as much as how long you've had A beta in your brain that is predictive. And so they're doing some really unique and creative modeling to look at the level of the PIB is a marker, is a neuroimaging tool to measure A beta in the brain. And looking at the deposition of A beta in the brain, they see that if you look at just modeling it by age, you don't get much of a relationship. However, if you model it based on an estimate of how long a person has had A beta, you see this nice model emerging, this nice tight relationship between chronicity and risk or likelihood of being positive on scan. So the really exciting thing, I won't steal Toby's or Rebecca's story on this, but they're doing some really interesting work where a single scan can be really informative. Again, no criticism, Toby, but this is something you have to go to the hospital for, right? Let's see if we can do this with other types of markers. These data have been replicated in other cohorts as well. So this is an emerging story that it's not so much your level of A beta in your brain, but how long you've had it, which kind of makes sense. If we go back to that model of preclinical Alzheimer's disease, we think that you've had this disease, these depositions for 20 years, certainly that would be suggest that you're at greater risk for the disease itself. Okay, so other models, again, at the Alzheimer's disease progression, but however, this is a major critique. This is largely from data on white populations. The inclusion for these studies has been abysmal. We're trying to do better. Colleagues of mine are making major efforts to be more inclusive. What am I doing for time? Okay. So this is Rebecca Kosick's work. Also, again, a thread that we want to pull on. She had data from March where she looked at those African-American individuals who had both plasma and A beta PET. And what she found was that there was, if you looked again at age and PET status of positive versus negative, the blue group are those individuals who are positive on PET scan. The red group are those individuals who are negative in terms of they do not have amyloid deposition meeting criteria for a positive scan. And then look at whether or not duration sorted. If you looked at it by duration, the groups sort out very nicely. So the relationship is there, emerging out with our African-American participants' data. And lastly, if we look at that, again, that chronicity or earliest age of onset of amyloid, it was a strange finding that those individuals who were PET negative actually seem to have a steeper decline in their plasma in terms of, again, moving towards pathological. However, when you adjust it based on chronicity or earliest age of onset, you see that relationship sort out much more in an expected range. So again, the blue line are those individuals who are negative. Those individuals who are positive are in that red dashed line. And you see that when you sort by chronicity, this slope makes much more sense in terms of our models of Alzheimer's disease. So this is a conversation I have all the time, both with my Oneida friends and the African-American colleagues and community members, is we have to be able to trust that these models make sense across the board. We have to be inclusive in order to build trust. We saw this with the trust was a major factor in whether or not people chose to get the COVID vaccine. Trust can completely undermine all public health efforts. So we have to bake into our science efforts to make sure that we are inclusive so that we build that trust into our data collection. So our score was in a 14th percentile, so we're hoping for a notice of grant award, hopefully any day. Excited to continue this work for another 5 years. So our aims as we go forward, to test that amyloid hypothesis, really in an African-American cohort, and especially an African-American cohort that's in that middle stage of life. So really important work that we need to do to make sure that this is something that's broadly applicable. We're going to also examine that alignment between plasma A beta and tau measures with the PET neuroimaging. This is, again, our goal is to be responsive to what we're being asked to do. Get this out of the university and something that we can use more broadly, so that people can actually go to their clinic in northern Wisconsin. They can go to the health clinic at Oneida and feel confident. In this case, our African-American participants can feel confident no matter where they live in the state. They don't have to necessarily come here to get the information. And this is what I'm really excited about. Our third aim is a science of recruitment aim. We're going to look at what has worked in terms of enrollment. We're continuing enrollment. We plan to get to 500. I think we will easily exceed that. I don't think that the program officers will stop us if we go over 500. So we want an active cohort of 500 African Americans who are invested in discovering Alzheimer's disease treatments and cures, hopefully. So what we're doing in Indian country. So this story started a little bit later than my work in the African American community. So in 2015, as I mentioned, I was asked to give a talk. This led to a whole series of trips to Oneida. At some point, it expanded to the point where we developed an advisory board. And I would go to Oneida before the pandemic. I'd go up to Oneida once a month for our advisory board. Formed some of the foundational relationships that have helped us do this work. Here's our cab. We responded that this was a major request right from the get-go. Veterans need to understand this because we were talking about risk factors. Veteran status, unfortunately, raises your risk for Alzheimer's disease. So for those who are familiar with American Indian culture, being in the military is a major thread that is woven through the culture. And so you'll see that there's a overrepresentation of American Indians per capita in the military. So we responded, my colleague Cindy Carlson wrote a supplement to look at engagement with veterans. Major thrust was to engage with American Indian veterans. We do a lot of work at this point with like meal delivery, care boxes. This is during the pandemic. You'll see everyone's got their mask on. And this has led to a really rich research partnership. We have an R01 funded called the iCare grant. We just recently started our AMICA grant that just got funded this year, where we're going to adapt a cognitive test to make sure that it works with American Indians. It came out of the Kimberley in Australia. The Kimberley Indigenous Cognitive Assessment was brought to Canada, and now we're bringing it to the US. So from our first project, we developed a community report where we interviewed individuals when they talked about dementia and dementia resources. So out of this is real world benefit for the Oneida community. We presented this to our community advisory board. We presented it to the business committee, which is the governing body of Oneida. And then finally, we presented it to the general manager at Oneida with concrete examples of how dementia care could be improved based on the feedback we were given by our partners. So I want to, again, to think about like when you make broad investments in a community, it's not just about going in to collect data. Ask the questions like hire people from the community. We make a concerted effort to work with Black-owned businesses and Oneida-owned businesses. And I will tell you, one of the hurdles to doing this is dealing with fiscal and HR policies at the university. Again, not so hidden hegemony about the right way to do things, right? I am so fortunate to have really good partners with Colleen Roper and Lindsay Rowe and Chris Bears, who are really willing to work with us to make sure that we get through these hurdles. because this is not an easy task. So key to have those key partners in HR, Patrick Hansen. I want to call them out because of the good work they've done to support this effort. Very important point too. We get asked this from the community all the time. Who are you bringing into the ranks? How are you helping with trainees who look like us? How are you supporting that? So I work closely with NACHIP. I work closely with other programs, the Shapiro program, that bring in trainees who are underrepresented in science and in medicine to make sure that people coming through the ranks, I see myself as a placeholder. I want to be replaced by people who are serving the communities, who look like the communities that they're working with. So, soapbox moment, if I may. How am I doing for time? Okay. The first step is just acknowledging our culture as researchers. And I think redefining how we think of recruitment. Many of us go into this saying, well, I'm just going to look at the numbers of people I've recruited. The numbers are a testament to the success you've had in engagement. And when you start to, I'll say this too, as you start to gain status, when you get your R01s and things like that, what you don't want to do is abandon that philosophy. It actually is going to be more effective for those with status, moving that circle, moving us to the borders of our current circles. So I encourage any of you in the room who have R01s, who have the status, this can't fall to the junior people to make these changes. This is from the 1993 NIH Revitalization Act. How many people have heard of this? Yes, thank you. So this was, decades ago, and the mandate was not controversial. The graphics at the top show the vote. The Senate and the House supported this, that we had to be inclusive in our research. They used an old term, minority. Most people prefer to not refer to minority and said minoritized or racialized. In this case, that people were systematically excluded from research if it required engagement and consent. I'll put a little caveat there, that we had to actually be inclusive. It mandated it, but there were no teeth behind it. So obviously we have not done a good job and there are no consequences for it. So if you ever wonder why you include those segments in your grant applications where it says your plan to include minorities and women, it's because of that 1993 Revitalization Act. And colleagues I'm not the first one to make this comment, like, why are we not doing what we said we were going to do? Why is NIH not holding us to account in terms of what we plan to do for our enrollment? It's a matter of justice. In my soapbox moment, if you can indulge me, those who have the highest burden of the disease should have the benefit. It should be included. It, again, baked into our science, so there's trust. It can't come late in the game where we then bring this to the community and say, trust us, it'll work with you. They need to feel included from the get-go. So I think those are, I want to show you my team. I want to just brag on them and how great they are. I might be the one whose name is on the R01, but behind that is this amazing team who are doing fantastic work. So people have to trust, obviously. They have to feel like that it applies to them. And we do that with inclusive work. And that's the only way I believe, and not the only, it is a prominent way that we can move the needle finally on health disparities. So here's the leadership of the Inclusion of Underrepresented Groups core. Really drew on expertise, not necessarily degrees. So it's not necessarily an MD or PhD that drove this decision for leadership, but who had the expertise. And then the staff, the amazing staff who are doing this fantastic work. On the left-hand side, we have the outreach team for the Oneida. On the bottom right-hand side, we have the outreach team for the African-American community. Our leadership, emerging leadership, is Carey Trojancic and Tiara Smith, who are emerging leaders in our program, who are taking on more responsibilities for program. Carola Ferracimo, who's like the glue that holds us all together. The staff at Oneida, the team of students, and also our two newest hires who are working as coordinators in that RAP and ADRC cohort. So I think that is my last slide. I just want to again return to that idea of recentering how we do this work. Let's move to the borders, and let's bring the world with us to that border and recenter how we're doing this work. I make this last point because doing this way interdigitates our diversity, equity, and inclusion efforts. We can't do siloed diversity, equity, and inclusion. It has to be interdigitated with what we're doing in clinic and what we're doing in our research. That's it. Thank you. So I can take some questions. Do you have any questions online or no? Okay, I can take questions from the audience. Okay. Yeah.
Is there, you found a difference in male versus female recruitment?
Yeah.
So how do you address?
That's a great question, Farah. So the question was, is there a difference between for gender identity for men versus women? Absolutely. Yes. So in large part, just a general characterization. This is not the case across the board in all settings, but most settings, it's women who volunteer from these groups, from underrepresented groups, and it's harder to engage men. And we've addressed this by really looking at programming that engages men in conversation with this, instead of just asking their spouses or their daughters to bring them in. So good question. Yes, it is something that we've made a conscious effort to try to improve our representation. So so Dr. Chetty, excuse me, yes, thank you, Dr. Gleason. So appreciated hearing about your amazing work in thinking about our own culture and that of others. What have you found about culture based on age through your cross-generational work? Have you experienced the need to shift perspectives as a researcher based on important outcomes based on age? Great question. Yes. Culture is not a uniform, static process. You see, I do see shifts, especially in conversations around gender identity and a different comfort level. And sometimes those clash. It's interesting that we've gotten to some really I think heartfelt and important conversations around the use of honorifics, Mr. or Ms, as we do this work, and whether or not that's something that makes sense with the younger generation. So yes, it's an emerging story and one that we just have to be constantly thinking about, like a sensitive approach, and listening is really key to understanding that generational shift. Yeah.
I'd be really interested to hear maybe some of the unfiltered comments that you got when you presented your results back.
Oh, yeah.
Excitement or things that were surprising or what was the reaction?
So Lauren asked for some of the unfiltered comments when I present to the community. Sometimes when I first started doing this work, some of the unfiltered comments are like, we don't need to hear that we're at the top of the list for risk anymore. You know, stop telling us that, we know it. And it was more like, well, we want you to tell us what we can do about it. As things have changed, I feel like the comments I'm getting now are mostly they're relationships now. So I feel like the comments I'm getting are more on a personal level of like what this means for me. I'm beginning to talk in the communities about the disease modifying options. And communities are like, we want this, you have to bring this to us. So I would say some of the unfiltered comments are more on the positive side. We want to be part of this, but we want to be included in a way that is respectful. And we can do that. We've done lots of hard things. We can do engagement. Sometimes I get unfiltered comments from the science side who are saying, well, this is too much time. It takes too much effort. We can do it though. Yes.
Fantastic conversation.
Yeah, thanks. Oh. great question. The question is, how do we share results with people when we're, I presume, in those cases where we're finding amyloid deposition, higher or lower levels of amyloid in the plasma, maybe they're cognitively healthy. I have such great colleagues. I'm so fortunate to work as part of a team. So my dear colleague, Lindsay Clark, is actually just submitted an R01 to look at those disclosure practices. I'm going to ask her to guide that story. I don't believe we can rest on our laurels and just say, hey, it's scientific. We don't know how, we don't have these tested yet. Put yourself in that position. If you knew you had a elevated level of amyloid in your brain, what would you want to do about it? Especially as these disease altering drugs are coming to market. I'm going to look to my colleagues who are expert in that area to guide that, but we cannot ignore it as an issue and a concern. Thanks. I appreciate you all listening to my soapbox moments. My teenagers are well beyond listening to that, so it's nice to have a receptive audience. Okay, it looks like one more question for Monica Bruce. For students from underrepresented populations who are interested in doing this work, what programs do you recommend? It depends what their training background is, but I would start with, if you're in medical school, the Shapiro program and the Rush program. If you're interested in doing this work and you're in a PhD program, I recommend finding those researchers who are doing that work and begin to engage the communities. I know NACHIP, I'd start with NACHIP too, would be another option for those who are Native American. So I'm sorry, I can't answer that completely, but I would say talk to people and find out where those avenues are. They're there. All right, well, thank you. I think that wraps up.